Good evening, and I welcome all of you to this session on PG mock exam conducted by the Academic Wing of Kerala State IRIA 2022. I welcome Dr. Gomadi Subramaniam, our State President IRIA. Dr. Gomadi is a multi-talented personality with great interest academically and socially, and the mastermind of this whole event. I also welcome Dr. Rijo Matthew, our State Secretary IRA, Dr. Venugopal, HOD RCC, our Chief Academic Coordinator, and Dr. Ramesh Shenoy, our Program Coordinator. And we are fortunate to have here Dr. Leena from Vellore, who will be conducting the sessions. And I'm really grateful to her for accepting our invitation. And we have 4 cases for discussion today, and we have 2 candidates with us. And Dr. Leena would be showing the first set of cases to Dr. Nesri. Case 1 and case 4 would be meant for Dr. Nesri, and Vaishak would be doing the next set, that is case 2 and case 3. Both are final year PGs from Kerala.
Thank you, Dr. Mara. Shall I start sharing or?
Dr. Venu, can we start?
Okay. No problem. Anyway, you welcome all, and I am happy that actually Dr. Leena is on platform. And Dr. Leena, just one word. She is actually moderating today's program, this residence program. The residents are actually, there are 2 residents, one Dr. Vaishak and Dr. Nisreen. Dr. Vaishak is from Government Medical College, Alleppey, and Dr. Nisreen is from Pushpagiri. And actually, this program is being moderated by Dr. Leena, and she is professor in cardiothoracic section, Department of Radiodiagnosis, Christian Medical College, Vellore. A hearty welcome to Dr. Leena and also the residents. And also, I welcome the state IRIA President, Dr. Gomadi, Secretary, Dr. Rijo, and Program Coordinator, Dr. Ramesh Shenoy, and also Dr. Tara, because actually she did all the work to arrange this program. I welcome you all, and also I welcome each one of you who is attending this program. And this program is actually, this platform is actually provided by JournoMed. And I welcome all of you once again to this wonderful program. And as everybody knows, the cardio is little difficult. Nobody is actually paying much attention now while going through this residency program now. But still, we don't know, we may be getting some short cases and all. We think long cases may not come, but still short cases and spotters, of course, will come. So today is actually the entire month was devoted to cardiothoracic imaging. Once again, I welcome Dr. Leena, and over to Dr. Tara, if any.
I think Dr. Leena can start the sessions right away.
Okay.
And case number 1, as I've already said, is to Dr. Nisri.
Okay. So thank you, Dr. Tara, Dr. Venu, Dr. Gomadi, and all the organizers for this. To be honest, I was also quite surprised that there's a very organized team in IRIA Kerala compared to, I think, the other states. I think a lot of effort has been done for this PG teaching. Congrats to you all. And that too, I was very impressed by the fact that even specialty wise, and when I heard from Dr. Tara about all the cases which has been already dealt, I was like, oh, that's really amazing, because usually at a PG level, we usually don't cover such a wide variety, but it's really good to know, because cardiac imaging is an advanced, I mean, it's a field which is growing faster compared to what we all were doing PG level. Now, because of the cardiac MR being more available, more imaging is done. So it's good to know, not only as a practical point of view, but I have seen that in the last few years, some theory questions will come. And few maybe, like sir said, there may be some short cases, but usually it is on the lesser side, very less, but it's always good to know, and definitely in your practice, this will come in. and more in the coming years. So it's good to know that. So, but I want to assure you that I'm not trying to make it like very hardcore questioning. It will be like more of an interactive session. I will just lead you to how things to be looked at. It will be more into those terms. You don't have to really worry about which sequence we can, because these are not all the senders will have cardiac MR. So we are not expecting everybody to be knowing in and out of it. And even I myself have learned it because of my fellowship and all those things. So I think it's a known thing that at a PG level, we may not get an exposure of that much cardiac imaging. So you don't have to worry too much about how it will go. Just relax and just take it. Just think of it like, suppose this came for your routine reporting. How will you look at it? At the end, you have to say, okay, this is what I'm seeing. It's now from there, we can direct it to which direction, how to go. That's how we will look at it. So just relax. And Dr. Nisreen and Dr. Vaishak, congratulations, I should say, for taking up, and because you have to be bold enough to come to this platform also. So stay calm, and we will start with the case 1. I will start sharing. So Dr. Nasreen, what I would say is I'll just first go through, just show all the slides which I have, and then I will come back to the slide 1 so that you can then start, so you know what all are available. Is that okay, Dr. Nasreen?
Yes, ma'am.
Okay. So this is my first slide, and then this is again part of the same thing, whatever it is, you can figure that out. I will come to it. And next is this study, or the sequence, I would say. And then I'm just going through the sections, and then it is coronal of that same thing. I'm trying to show some things here. And then I've shown the sagittal of the thing, and that's all. So we'll go back to the first slide. So basically in that, so do you want to start telling what it is? First, you can just, what we are looking at.
Okay, respected faculty, myself, Dr. Nisreen from Pushpagiri Medical College, Tiruvalla. I have been provided with plain and post-contrast images of cardiac CT. Here I am seeing axial plain images, where I am seeing the oblated hyperdense.
Dr. Nasreen, can I ask you one question? How did you say for sure from this particular section that it is a CT cardiac, it is not CT thorax?
Because it is a more focused image. If it was a CT thorax, the field of view would have been even.
Okay. One more, like what happens? What is the key difference between the CT thorax or thorax versus a CT cardiac? What is the key difference?
Cardiac CT would be ECG gated imaging.
Correct. Yeah.
To prevent artifacts.
Yeah, due to the pulsation. So the moment you start seeing the coronary arteries or even the cardiac chambers more clearly without much pulsation artifacts, then it is likely it is a gated study, because sometimes on a plain section alone to come to a conclusion on that will be a little difficult, but I agree with you because it's gone down to the cardiac area. So you think it is a CT cardiac, and you can also look for these things like whether you are able to see the coronary arteries more clearly, because in our regular CT thorax non-gated, we won't be seeing it that clearly. It will have that pulsation artifact. So the moment you start seeing that, that this is a gated study. Now, whether it is retrospective or prospective, it will be difficult to make out just on this images alone, unless we know how the technique was done, or if we have seen any of those protocols. Otherwise, it's difficult. Okay, carry on. Yeah, so you have been provided with this. Okay, do you see anything abnormal, normal?
I can see a lobulated hyperdense area.
Very good.
Seen at the region of aortic root.
Very good. Yeah.
There is speck of calcification, a tiny focus, hyperdense focus, which may be a speck of calcification.
Okay, you're talking about this focus?
Yes,
or-
ma'am. Yes, ma'am.
Okay. I think that should be Dr. Tara, just for confirmation, what is the time for each of these cases?
I
Dr.
think you can take 20 minutes, 20 to
20
20 minutes.
Okay. Yeah. I think then we may not be able to go much details. Yeah, let's go to the next slide. Otherwise, I think we may not finish all the various findings. We will come back to this particular. Is there anything else you want to highlight in this? So you mentioned there is a hypertension. Yeah, correct.
I'm not seeing any blood hyperdensities in the region of pericardium to suggest hemopericardium. I'm not seeing any pleural effusion.
Why did you say you are not seeing? Because that's not a usual thing to look for. No, why? What made you to think of hemopericardium?
Since the hyperdense lobulated area seen in the central region, it is of I think it is of blood density.
I'm not able to hear. Am I?
Hello, ma'am. Am I audible?
Yeah, I can hear.
The central hyperdense area looks like a blood densities. So hence I am looking at the pericardium for any other blood density.
Okay. Yeah. I think I didn't show you this one. No, I started with the second set. Okay. So here, what else are you seeing?
Here again, I'm seeing a well-defined ovoid collection with internal contents showing concentric layering, as well as hyperdensities with the central areas as well as the dependent portion of the peripheral area showing more hyperdense. So probably this collection contains blood clots of various age.
Okay, just one correction when we are discussing, sometimes it's better not to jump into the word collection. I think the first time when you say you saw there is a hyperdense focus, that focus is fine, because the moment you say it's a collection, then we can take it into a different route. So I think the lesion or focus, those region I'm seeing in the aortic root, because you saw the next slide where you saw this, you already saw, right? So now we are trying to, it's just one set of sections above it, so you can actually see this particular hyperdense area, right? So it's better to use the word hyperdense focus noted at the region of the aortic root is seen extending into the aortopulmonary region, rather than jumping in and saying it's a collection, because then it's going in it. We are not sure yet. No, we are not seen the case yet. So it's until we are finally clear it is a collection, then we shouldn't be using those terms in the beginning when we are only given a limited. It's better to use the term. What you mentioned about the hyperdensity, all those things are correct. So only the word collection I probably wouldn't entertain. Okay. Is there anything else you want to tell?
Again, here again I'm seeing the speck of calcification, which is at the periphery. It is not it is not displaced internally, as would be in the case of a dissection of any vessel. And this lesion is abutting the pulmonary artery at the supromedial aspect.
Okay. So based on this particular, so what images you said? You said CT cardiac. Do you think this is with contrast or without contrast?
The given set of images are that of plain study.
Plain study. Okay. So based on this, where do you think is the lesion?
Aortic root extending to aortopulmonary window.
Okay. Yeah, I think I agree with you completely on that. I think that's fine with it. So now, what are your differentials when you are seeing this much on a on a plain study?
I would like to consider an aneurysm arising from the aortic root.
Okay, like where? So from the aortic root, what is there?
Aortic sinus of Valsalva.
Okay. Anything else? So suppose if this image was there,
left pulmonary artery.
Yeah, I think at this image, I think it could be other vessels also, like, you know, even one of the coronary arteries or any other fistulous communications, even pulmonary artery, left pulmonary artery, though we are not seeing the pulmonary artery, but it is in that region. I agree with that part. Okay, so since we don't have much time, we'll go to the plain contrast study. So you can probably, this is my first slide, this is my second slide on the axial. So I will go one by one. Probably you can start seeing these images, you can describe it, then I will move to the next slide.
The central lobulated lesion does not show any post-contrast enhancement.
What were you trying to imply with that?
That it is not a solid lesion.
Not exactly. Not all solid lesions should. So see, here you are seeing something at the aortic root, right?
Yes.
And you are giving contrast. So contrast is coming into the left ventricle, and you are seeing this particular lesion, and then you are seeing the aorta being opacified. So what are the thoughts in your mind? Okay, I'll go to the next section also. Maybe that will give you a clue too.
The contrast is flowing from left ventricle to the aorta. There is no obstruction. I mean, there is no complete obstruction.
Okay,
and
but you
also,
mentioned something about solid lesion. I didn't get that part. I think is probably not a correct word. What else you can
I'm
say?
not seeing any acute contrast extravasation into this lesion.
Yeah, contrast extravasation, when we use the word, it is like when you are saying about what does that mean? It is in a particular lumen. You are thinking it is outside of it. When it comes outside, the word extravasation.
Yes, ma'am.
So here, are we sure that this is? I think the word, sometimes when we are not very sure yet what we are dealing, it's better to say there is no contrast filling of this lesion, or it is not opacified with contrast, so that you are still keeping all your differentials open, you know, so that you don't have to, when you say one particular word, then you are narrowing your root. So keep it as it is not opacified with contrast, but don't, it doesn't equal to what you mentioned as solid lesion. That is not correct. It just means that it is not opacified with contrast. So what are the conditions? You saw it is hyperdense on the non-contrast study, but on the contrast study, it is not opacified. What does that mean?
It must have been thrombosed. The lumen is not patent.
Okay, so it is something a clot, blood clot. It is not a actively bleeding. So hyperdense, it could be even an active hematoma, isn't it? Yes. But here it is something which is not actively bleeding. It probably, whether it is thrombosed or whether it is partially thrombosed, we don't know the rest of the images. Okay, so now you are still keeping all your differentials open. So let's look at the other images. So now from this, what else can you, I don't know how much more we can zoom it out. I think I can't zoom more. Okay, you mentioned that it is not obstructing the left ventricle outflow tract. Is that what you mentioned?
Not completely obstructed. Not
okay. 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 Do you want to look at these images? I'll just show this and this. Do you want to comment on any of these?
The part of this is seen by protruding into the aortic root.
Okay.
I can see it bulging into the proximal most aspect of the ascending aorta.
I didn't get that part clearly. Where is it protruding into?
Just above the and anterior aortic sinus.
Okay. Now at this point, okay, you're talking in terms of aortic sinus. So let's come to that. So how many sinuses are there normally for aorta?
3, ma'am.
Okay. How do you name them?
Right anterior aortic sinus, left posterior aortic sinus, and coronary sinus.
I think commonly used terminologies are right coronary, left coronary, and
non-coronary.
And as you mentioned, right coronary is anterior and left coronary is posterior. The words facing sinus we use often in terms when we deal with this transposition of great vessels, when we have this nomenclature, when we look at the aortic route from the non-coronary sinus, pulmonary artery to non-coronary sinus. So that's when the words facing, anterior facing, posterior facing. Otherwise, in a normal, congenital heart disease or in a regular routine CT coronary, I think you can use the words right coronary, left coronary sinus, but it's always, you shouldn't confuse it with the coronary, actual coronary sinus. So some people use the word coronary aortic sinus, left coronary aortic sinus, and the non-coronary sinus. So in this, you mentioned, so where is this located in terms of the aortic sinus? This is the coronal image. I'll just go back once more. And this was your axial sections. Okay. So it is seen in relation with which coronary?
Right coronary sinus, ma'am. Anterior coronary sinus.
Okay. I think that is not correct. See, look here, no, right, left. Okay, now I'm going back. Right, left. So where is this coronary, I mean, what you are seeing, this particular lesion, where is it seen in relation to?
Posterior.
Yes. So this is the left coronary, right? You can even, what is this?
Left circumflex, left coronary artery.
I think that's it. Yeah, I think at this point you will only be seeing left main coronary because
left
it
main
divides.
coronary.
Okay, this is the left main coronary. So what is it doing with the left main coronary?
It is superiorly displacing the left main coronary.
The lumen, okay.
Narrowing the lumen, compressing it.
It's compressing. Okay, so that is important. Okay, so these are few things. So one is the location, where it is located, which coronary sinus, if it is something with the aortic root, these are the things you should comment on. And one more thing is, third thing is with relation with the coronary artery. Is it away from the coronary artery? Is it compressing? Then one more thing which you mentioned earlier, but now can you relook into it and tell me what is happening here? This particular region. So this is the aortic root. This is the left ventricle. What will you call this area?
Left ventricular outflow tract.
Yes. So is it? How is it in?
It is causing narrowing. It is narrowing the left ventricular outflow tract.
Okay, correct. So now I'll show you the next section. Can you see any other coronary artery here?
I can see one more right coronary artery.
Yeah.
Atrioventricular groove.
Yeah. And does this image give you any extra information about anything else?
Oblique sagittal views. It is also
This is true sagittal.
Okay, ma'am. I'm sorry. It's also intending the right ventricular outflow tract.
Okay, correct. So these are the main things which you should comment on this, because that is important, because even on your axial sections, you can make that out. See, it is going into the RVOT, isn't it? So RVOT as well as partially into the LVOT is this particular lesion is protruding into. Now you can come to your, I think you fairly mentioned all the findings required for this particular case. So can you summarize and tell, now you can put all the findings together and tell me what do you see?
Ma'am, I'm seeing well-defined lesion arising from the probably arising from left coronary sinus and extending cranially into the aortopulmonary window. It is seen protruding and narrowing the left and right ventricular outflow tracts. And this lesion is not showing any contrast or opacification after contrast administration. Neither I am seeing any acute contrast filling of this lesion. Also, it is superiorly displacing the left main coronary artery, causing narrowing of its lumen as well as compressing it. So, I would like to.
So, because of its location, what do you think is the likely diagnosis?
It is an aneurysm arising from the left coronary sinus, sinus of Valsalva. It's a.
So, do you think it is just a? So you use the word lobulated, no? So what does that indicate? So normally, if you were saying it is an aneurysm, how will it look like? Normally, what are the two main types of aneurysm you know of anywhere in the aorta? What are the two main types of aneurysm you call?
Ma'am, saccular and fusiform.
Or saccular or?
Fusiform.
Yeah. So does this, so suppose if you're thinking of saccular aneurysm, how does it look? It will have a very rounded, smooth shape. Is this looking like that?
No, ma'am.
So what could have happened?
There might.
And you saw the plain CT also, no?
Yes, ma'am.
You started saying that it's a hyperdense lesion. That is how you started. That was correct. So now you put things together and tell me how can you connect these two?
Ma'am, there might have been an aneurysmal rupture.
Okay. So is it actively leaking?
No, ma'am.
Okay. So what will you use the word?
Contained.
Contained rupture. Yeah, I think that is the correct word to use. So this, so your final, so how I would summarize these findings will be, so there is a, on the non-contrast CT, I can see there is a hyperdense lesion in relation with the aortic root, which is also extending into the aortopulmonary region. On the contrast study, I can see that this lesion is not actively filled with contrast. However, it is seen in relation with the left aortic sinus of Valsalva, or left sinus of Valsalva, or left aortic coronary sinus, and it is partly protruding into the LVOT and into the RVOT, and also superiorly displacing the left coronary artery and partly compressing it. So in view of its location, it is likely to be an aneurysm in relation with the sinus of Valsalva. However, there is no active leak, and because of its lobulated appearance, it is likely a contained rupture, which is thrombosed. Okay, I think I'm quite happy with the way, because this is the way you have to say it out. See, don't, any difficult case, even in exam also, like when we start looking at it one by one, you'll be able to reach the diagnosis. Okay, so that is good. So now I will, shall I go to the, so one more thing is, what are the, I mean, with respect to the questions which can be asked in exams are, so one is about the cardiac CT itself, the technique, how it is done, and what is retrospective versus prospective. Do you know these things? If you're sure, you can say it out. Otherwise, read about it, because these can come in for your theory also, retrospective gating, prospective gating. Other things are with respect to the coronary artery. Then, so this sinus of Valsalva aneurysm, it's not a very common anomaly, but it's something which they have to address, and if it is actively leaking, they have to surgically correct it also. So in terms of clinical management, it is important that we radiologists pick it up and tell the clinicians so that they can give the appropriate treatment. Okay.
Yes, ma'am.
Dr. Tara, shall I go to the next case? Or any of you want to ask questions?
Yeah, I think, like, you know, I can't see anything in the chat box, but then this is such a nice case, and you're such a good teacher and a good examiner, Dr. Leena. Can you just give us a follow-up of this case also? Because Most of the
Yeah,
time, the
yeah.
examiner
Yeah,
would ask us about the management also.
yeah. Actually, this case, see what happens is when it's a contained rupture, if the patient presenting with contained rupture, I think this kind of cases we can follow it up. But if it is in an actively with hemopericardium, they will have to often surgically manage it. They may have to remove the aortic root and the graft have to be put in. Usually it depends on the clinical presentation also. Sometimes it will be like this patient, I think, was stable, and but if the patient is acutely presenting, they will have to have a surgical intervention depending on how acute, and like Dr. Nasreen also mentioned about there's no hemopericardium. So all those are features to tell that this is not an active leak. So I was also happy with that, the certain critical things which has to be mentioned, she mentioned, that is good. So I think this is this case is, the way she had presented is also quite good. I think I'm sure all of us learn by looking at small, everything when we go step by step, I think it becomes a little more easier. So I'm happy with it. So management wise, I think depending on the presentation is probably in this particular case, we can say this was not actually surgically managed immediately.
Okay. I think the second case is to Dr. Vaishak. So,
Okay,
Dr. Vaishak is there.
I'll just open my second page. Good evening, Dr. Vaishak. I'll just open my second page.
Good evening.
Okay, Dr. Vaishak. So like how I did for Dr. Nasreen, I'll first show you what are the images I have. Okay.
Yes, ma'am. Yes, ma'am.
And then we can take one by one, because sometimes not all
Sure.
the findings may be seen in all the sections, but some things I've kept it just to show how it is the rest of the things are. Yeah, I think I can go back to the first one. Maybe what you can just start describing what you are seeing, and then once we reach particular findings, you can highlight them. Okay, so over to you, Dr. Vaishak.
Okay. Here are the axial sections of the contrast lens CT at the level of the arch of aorta as well as the main pulmonary artery.
Okay. Okay. Anything? Any abnormality you are seeing?
No gross or abnormality seen in these sections.
Okay.
Can I go to the next slide?
Yeah, I just have one question to ask. What do you think is this? What do you think is this?
PDM.
Okay. Do you want to give a little more adjectives to that PDA? Is it active, or is it what density you're seeing there?
It appears hyperdense.
Meaning, what does that mean?
Calcified.
Yeah, correct. So it's likely a calcified ductus
Calcified
arteriosus.
PDA.
Yeah,
Okay.
correct. Okay. Anything else you want to comment on? What do you think about the pulmonary artery? How often will you see the pulmonary artery?
At the level of arch of aorta, yes, it appears dilated.
Yeah. Okay, so that is a clue always. Whenever you start seeing pulmonary artery at the level of the aortic arch, that's usually dilated. Okay. Sometimes in congenital, when there is rotation, you can start seeing them little more earlier if there is malposition of great vessels. But often in such cases also it will be dilated. But definitely in this kind of scenario, when a normal left-sided aortic arch, you start seeing the pulmonary artery, it is slightly dilated. And one finding you picked up is the calcified ductus arteriosus, or at least it looks like the walls are calcified. We are still not sure whether there is actual flow into it, because sometimes there can be a very tiny flow, but that alone, even if there is a shunt, is not enough to cause this much pulmonary artery hypertension. Because is this a child or an adult? Looking at the image, what do you feel?
I think it's an adult patient.
Yeah. So in an adult, just having a tiny flow, even if it is patent, it cannot explain a dilatation of the pulmonary artery. So whenever you are seeing pulmonary artery being dilated, what are the things which goes through your mind? Why the CT was done?
And one of the common cause for the dilatation of pulmonary artery is pulmonary artery hypertension.
Yeah. So what are the causes?
Why the causes of pulmonary artery hypertension? This CT can be indicated. As per it is broadly classified into 5 groups, ma'am. First one, any pulmonary artery causes, like any idiopathic cause or any connective tissue causes.
Okay.
And then it can be because of the left side of the heart related causes, any systolic or diastolic dysfunction, any valvular abnormalities, or some pulmonary parenchyma related problems like any ILDs or COPD. And then sometimes because of pulmonary thromboembolism. And some unknown causes for which the mechanism cannot be explained, and some shunts also, right to left shunts, as well as anomalous pulmonary venous connections.
Okay, so whenever you so what all things on CT you can pick up? So one is so in a case of pulmonary artery hypertension, you mentioned the cause. Okay, yes, correct. So one is the thromboembolism group. Second is the
ma'am. Any lung parenchyma related changes, ma'am.
Yeah, lung parenchyma.
ILD and COPD changes.
Yeah, ILD, COPD, connective tissue related ILDs, all those group which come. In that, again, there are 2 particular diseases. Which are those 2 diseases which have been named under the Dana point class? You know about the Dana point classification, no? I think that's what you mentioned. So in the Dana point classification, there is one category which we can, at least we can come to narrow the differentials on CT. What are those 2 diagnoses? Among the lung, it's a combination of parenchymal and vascular cause. Which are those 2 conditions? Yes, have you heard of capillary hemangiomatosis and veno-occlusive disease? These are 2 conditions where the lung CT will be helpful to come to the diagnosis. Obviously, they may have to confirm it in some cases with the CAT, but definitely CT will be helpful. So when somebody asks you why CT is being done, along with the parenchymal changes, the chronic pulmonary thromboembolism, you should also mention those 2 causes: pulmonary capillary hemangiomatosis and pulmonary veno-occlusive disease. And next is the causes related to the cardiovascular structures. You mentioned about the shunt.
Yes, ma'am.
Okay, because most of the shunts, let's say ASD or VSD, which one do you think, CT or echo, which is better to pick up? ASD, the usual ASDs and VSDs, which is better?
Usually first investigation will be echo, but better if any small.
No. Actually, echo is better for even small ones. Okay, see, atrial septum, interventricular septum, echo is better. We do have, if we do the proper studies on MR and all, but in our regular CT thorax, we can always miss them. So because of the movement artifacts and the pulsations, we can miss. So, but if it's not like we cannot pick up, it's just that sometimes of the pulsation artifacts, we can miss them in a non-gated CT. But if it is a proper gated study dedicated for it, or if it is an MR, then we can pick up even the smaller ones. But in a regular CT, we may not pick up the usual ostium secundum ASDs and VSDs. Okay, that is true. But there are few things in the shunts which we will be able to pick up. Which are they? On CT, we will be able to pick up. So these are the things which goes through your mind when you are seeing a case of pulmonary artery hypertension. See, where echo, the cardiologist are
anomalous pulmonary venous.
Yes, correct. So anomalous pulmonary venous.
The pulmonary veins, ma'am. Pulmonary veins, yes, ma'am.
Yeah, pulmonary venous connection. That is one. Anything else? Okay, we will come back to these things. So now these are the things in your mind, what you're looking for. Okay, let's go to the next section. Okay, what do you find?
In these images, the pulmonary artery, main pulmonary artery, as well as right pulmonary artery is dilated, grossly dilated, and larger than the diameter of the aorta.
So do you think just dilated, or you want to add little more? See, somebody is just listening to what you are saying. What do you want to say? It's markedly or grossly dilated. No, this
Yes,
is not just a mild
grossly
dilatation.
dilated.
This is significantly dilated. Yes, correct. And anything else you are seeing?
Mm.
Okay. Since I think you may not have you seen? Okay, there are few
In
things
this
which you should.
sections,
Okay, so remember, whenever you are seeing a section like this, so always
yes,
look
ma'am.
for the normal phase. So you are seeing the pulmonary artery, which is dilated, that you mentioned. You said the right pulmonary artery is
Yes, ma'am.
dilated. That is correct. Left pulmonary artery also you can see, maybe mildly, maybe not much, because here it looks sort of normal caliber. Then you are seeing the ascending aorta. And what is this?
Yes, we see, ma'am.
Okay. So SVC here, SVC here, SVC here, and SVC here. Is there anything
Okay.
extra?
Any right, one more contrast structure anterior to the right pulmonary artery, which is might be draining into SP.
So what do you think that will be? Is that
Any
normal?
right upper pulmonary vein.
Yeah. So whenever the clue is, whenever you see any vessel draining into the SVC from the lungs, see, usually in the CT thorax images, you only see the esophagus vein coming in from posterior, draining into posteriorly. You will not see any other vessel in a normal patient. The moment you see a vessel from the lungs draining into the SVC, that unless it's proven, it is likely to be a pulmonary vein, anomalous pulmonary venous connection. So here, because as you mentioned, it is in the region of the right upper lobe. So you are seeing the one pulmonary vein which is draining into it. That is likely to be the right upper lobe. Okay.
Okay.
Then what else you are seeing here?
Here, in this image, madam, there is a defect in the interatrial septum near the point of joining near the cavoatrial junction, ma'am.
Okay. So what does that mean?
It is like a type of atrial septal defect, possibly sinus type.
Yeah. So what happens normally here? What will be seen here? Normally, how will it be? So you are seeing there is a defect. So what?
Complete interatrial septum will be.
No, the interatrial septum will not be seen there. What else will be seen here? Interatrial septum will come only in the next section. This is your interatrial septum. Okay. But what will be normally seen here, though we put that, I agree, you said it as AS, interatrial septum, thinking that it is part of the ASD. But at this point, we don't actually see the interatrial septum. What will be seen? Normally, there will be a fat plane between the cavoatrial junction, the place where the SVC draining into the right atrium and the left atrium. This is a part of the left atrium. So there, normally you will see here this kind of fat plane. Can you see a fat plane here? So this is also a fat plane. This is what you will see here. Whereas in the next section, you will see the interatrial septum. This interatrial septum will connect to there, but that is here what you will see is normally, if you look at any other normal patient, you will see it as a fat plane, linear fat plane. Okay. And what else is you are seeing? Can you make out another vessel?
Yes, another possibly pulmonary vein. Right inferior pulmonary vein.
Okay, let me give you these sequences also, because so before you commit to inferior, because these are very limited sections, no, you cannot actually come to that conclusion of inferior pulmonary vein just on that. So I would suggest to look into these also. And now tell me, is that inferior pulmonary vein or not? Okay, maybe I'll show you these ones. This is which structure?
Left atrium, ma'am.
Okay, so what is this?
Yeah, right inferior pulmonary vein is draining into left atrium.
Okay. And what is this?
Left pulmonary left upper and lower pulmonary vein is draining into the left atrium, which is
Often
normal.
in the left side, it will be like one superior from the upper lobe. Often the lingula will comes as part of the upper lobe. So this is the left superior. Okay. So we can make out that these two are coming into the left atrium. Okay. Sorry, I'll just go back.
Okay.
So in these images, you can make out that actually this is the what we saw on the axial images is this image.
Yes,
so it's actually the middle vein, the middle lobe vein, which often the superior right superior pulmonary vein is formed by the upper and the middle lobe together. So that what we saw at the junction of cavo-atrial junction. Can you see this one? This one actually was the right side one coming into it, and also the superior lobe in this particular section from the superior segment of the right lower lobe also had one accessory vein draining into it. So all those things sometimes you may not be able to say from the distal, from these still images, but you can make out the key point you should say is that there was one, definitely the right upper lobe was draining into it, because at this level you will only see the upper lobe. And over here, because there were 2-3 artifacts, but you can see there is one more vein coming towards it and then another one here. So the middle lobe and the superior segments as accessory vein were all draining into this SVC, and these two were actually at the defect. What is the defect called? This is the superior sinus venosus defect. Normally, it will
sinus,
yeah. So normally it will be a fat plane. That is not there. So this is the clue whenever you are looking for superior sinus venosus defect. So you can actually next time when you look at your CT thorax, how is the SVC in relation to LA? Now, if there will be a fat plane separating the two. Okay, so that is how you separate, identify the superior sinus venosus defects. So these sections, we can make out the other pulmonary veins. So that is also important. Which all pulmonary veins are draining into the left atrium, which all are draining into the right atrium. So what is your diagnosis based, or can you summarize the findings?
In the given set of images, there is a gross dilatation of the main pulmonary artery as well as the right pulmonary artery. There is an anomalous, partial anomalous pulmonary venous connection of the right upper lobe, right middle lobe, as well as axillary venous structure from the superior segment of right lower lobe, draining into the right atrium or near the cavo-atrial junction. As well as there is a defect in the fat plane on the superior sinus defect. This might be the cause for the pulmonary artery hypertension.
Okay. Okay. And you can also mention about, when we mention about pulmonary arterial hypertension, you can also mention about
RARV dilated.
And also how the endoatrial
septum is dilated.
And also the interventricular septum is more straight, and often it will be more convex towards the RV side. Now here it is more straight. That also suggests there is volume overload. Okay. Okay. So this is good. So this actually is something we can miss on even regular reporting. Sometimes when if it is only one vein draining into the right atrium, the shunt may not be that big, and even the pulmonary artery may not be hugely dilated. But often, so this is the clue. Whenever you see any vein coming into the SVC, we should think that it is an anomalous venous connection. And also this, often this is a common association. So when you see PAPVC, look for this. Look for this superior sinus venosus defect, especially if it is on the right side. Okay, I think anyone else want to ask question among the faculties?
Dr. Leena, this is such a complex case which has been made very simple for the PGs and for the benefit of all. Can you just tell us about the HRCT findings in capillary angiomatosis and veno-occlusive disease? Because for the general radiologist, it's a little difficult.
Okay. So the clue is when there is a combination of pulmonary artery hypertension and pulmonary venous congestion. So often, I mean, this particular combination can come in a multivalvular heart disease also, especially when there is a lot of MS, MR with associated pulmonary hypertension. They can have venous congestion and pulmonary artery hypertension also. Otherwise, in other cases of lung parenchymal disease, we will often see a pulmonary artery hypertension. Or if there is a valvular heart disease, then this combination can happen. In the absence of a valvular heart disease, whenever you see that the pulmonary artery is dilated, and even there is features of pulmonary venous congestion like interlobular septal thickening, or even prominence of left atria, then we should think of these two conditions. Now, how to differentiate between these two conditions? I think there is a radiographic article which had actually looked into, and they have tried to separate out. So what they have said is the presence of pleural effusion and interlobular septal thickening are more common with the pulmonary veno-occlusive disease. And presence of centrilobular ground glass nodularity is common with the pulmonary capillary hemangiomatosis. Now, there can be some amount of interlobular septal thickening in capillary hemangiomatosis also. There can be less, but that is a less common finding. So whenever you see a lot of centrilobular ground glass nodularity, evidence of pulmonary artery hypertension, and plus minus pleural effusion, and features suggesting that the left atrium is also prominent, think of pulmonary capillary hemangiomatosis. But if there are more of interlobular septal thickening, bilateral pleural effusion, and pulmonary artery hypertension, then think of pulmonary veno-occlusive disease. But again, this has to be, it's a management decision which have to be, I think they have to do sometimes catheterization to see the pulmonary vascular resistance. Those are the ways you can, how to proceed with the case.
Thank you. Are there any questions? Like, can't see anything in the chat box, so I think we can move on to the next case.
Okay.
Case number 3 is also to Dr. Vishak, so I think he can stay.
Yes, ma'am.
Okay, I'll just. Okay. So I will again first go through the number of slides I have. So this is one set of slides. Actually, this is a scanned-in film which I have taken the screenshot, and these are just highlighted the relevant images for you to make the clear diagnosis. And this is a CT done in our institution after 1 week. This is also part of that same study. And these are the different planes. Okay, we'll start with this one.
Yes, ma'am.
Maybe, yeah, we can just probably start highlighting the main findings.
Yes, ma'am. And these are the axial sections, a series of axial sections, contrast length CT images of thorax. In this, I can see there is a presence of an eccentric cyclar outpoaching from the descending thoracic aorta with a peripheral eccentric thrombus.
Okay.
Yes.
It's of the same set.
Yes,
do you want to add anything more? So you mentioned there is a, what is your summary of the findings in these two?
Descending thoracic aneurysm, there is a cyclar outpoaching with a peripheral eccentric thrombus.
Okay. Do you want to? Okay. Do you want to look into any of the so whenever you are seeing a circular outpouching, that's what you mentioned, no?
Yes, ma'am.
Doctor, yeah. So circular outpouching, and you mentioned there is a peripheral.
Maybe it might be spurious, but there is some hypodensities noted filling the right atrium as well as right ventricle. Maybe it is because of
yeah, I think difficult to say for sure, because if you look at I think if you look at the lower images also, it's not fully opacified, no? So, I mean, it could be that it is concentrated for the aorta, and the right chambers are less opacified because of that. That we cannot 100% say for sure. So based on this, I agree with your finding of saccular outpouching. And you mentioned that there is a peripheral thrombus.
Yes, ma'am.
Do you want to add anything else?
Species circumferential thickening of esophagus, ma'am.
Okay. Okay, I think that is also very important, because normally we will not see this kind of thickening in the esophagus, right? Will you see normally this much thickening in a normal patient? Dr. Vaishak, am I? Sorry, let me just check my connection. I don't know whether. 1 second, I'll just share again. Am I audible or am I breaking?
Yes, ma'am. Yes, ma'am.
You're able to hear me well, no?
Previously, the audio was not clear, but now it's clear.
Okay.
Yes, ma'am. Yes, ma'am.
Okay. I'll just share again. I thought whether mine was. Okay. Yeah. So tell me, you mentioned about the esophagus. So there is a.
There is a circumferential symmetrical thickening noted in the esophagus adjacent to the saccular outpouching of the aorta.
Okay. So what was going through your mind when you saw that?
There are two possibilities, ma'am. One, if it is any malignancy or any infective etiology esophagus which is causing this aneurysm of aorta. The other thing being this is a mycotic aneurysm with a septic emboli that's supposed to be from somewhere else, and this might be the esophageal thickening can be reactive to this, secondary to the mycotic aneurysms.
Okay, good. Now, I just want to ask one question. You mentioned the first possibility. Now, here, when you look at this particular images,
yes,
which part do you think first would have come? Like, it's like, which is egg or chicken? Which is it the esophageal thickening which should have come first, and then this aneurysmal outpouching, or is it the aneurysm which should have come first and then the esophageal thickening?
One of the cause for mycotic aneurysm is infection from the adjacent areas also. So in that view, and I can also see the contrast of opacification within the esophagus. Either they have given any oral contrast.
They may have, to be honest, I don't know for sure whether they have given or not, because this was done outside, and
yes,
from the images here, like
yes,
if you look down, there is one small bit of what I feel as the stomach had a little bit contrast. So it is possible that they may have given, even here you can see little bit contrast is, or contrast density is seen. So what are again questions? So what are the possibilities if the contrast is not given? What is the possibility?
Any fistulous communication between the aorta as well as esophagus.
Okay, so I'll tell you now the history. So this patient actually presented with fever for 10 weeks, acute chest pain and dysphagia. That was the presenting complaint. Okay. Now with this history, do you want to so can you just summarize the findings with this history? What are the thoughts? 2 differentials. You can put 2 differentials, but keep the which you think is the first one.
Okay. Ma'am, a patient presented the complaints of fever as well as dysphagia and chest pain from the past 10 days. Present axial sections of contrastinal CT thorax images shows there is the presence of a saccular outpouching in the descending thoracic aorta with a peripheral eccentric thrombus, and adjacent to that the esophagus is showing a circumferential as well as symmetrical wall thickening with the positive contrast within. The details of the imaging was not clear, available. There are 2 possibilities. My first DD would be any esophageal, any mediastinal abscess or esophageal infective etiology with that is mycotic aneurysm with the first possibility. The second rare possibility will be mycotic aneurysm with the reactive inflammatory changes in the esophagus. It is less likely, I believe.
Okay. So your first possibility, you said it could be like a mediastinal collection. So I think you have seen all these images.
Yes, ma'am.
maybe you can probably make it more focused, because it's not the entire mediastinum is not involved. The rest of the structures are all looking normal. There is no
Yes, ma'am. Yes,
mediastinum.
ma'am.
It is diffusely. You're only seeing esophageal thickening. So
Yes,
you can probably say like this. So I am seeing these two findings. One is esophageal thickening, and the second one is the saccular outpouching from the. So one possibility, it is the saccular aneurysm, which is which is a mycotic with a reactive. That I agree with it. Second is so I think try not to use the word mediastinal collection, because we are not seeing any collection. No,
Right, ma'am.
it's a very focused area in the posterior mediastinum. Okay. So I think it is fair enough to give both the DDs at this point, because when you don't know for sure, but which is more likely to happen? Can a mycotic aneurysm leading to reactive esophageal inflammation, or the other way around, like a esophageal pathology causing mycotic or a mycotic aneurysm? Which is the more likely way?
In mycotic aneurysm, surrounding inflammatory changes will be possibly mild changes will be there, but in this there is significant thickening, so possibly primary infective etiology in the esophagus with the secondary mycotic aneurysm adjacent to that.
Yeah, I think that's probably what usually happens. Even when you see the mediastinal necrotic nodes with the ascending or aortic arch, often it will be the necrotic nodes which leads to the inflammation in the surrounding aortic wall that becomes dehiscent, and then there will be a pseudoaneurysm forming. That's the usual way happening. Again, if we have serial CTs, we know for sure what happens, but usually it will be the surrounding, whichever area is the infective focus, that can affect the vessels rather than a vessel problem leading into the esophagus. I'm not saying it cannot happen, but it's often what we see in the mediastinum, especially with mediastinal nodes, necrotic nodes, all those things. It will be the mediastinum, the structure will lead or cause the inflammation on the aorta. First, it will be like an aortitis, and then that will weaken the wall, and that will cause a pseudoaneurysm. Okay, so we have both. We are still keeping both these possibilities, but more likely it will be a esophageal infective focus causing a aneurysm. That's commonly. Let's see what happened after that. So, what are these images?
These are the non-contrast axial sections of the thorax. I think taken 1 week after the previous imaging. I think any pleural effusion with the collapse consolidation in the left lung, possibly.
I'm not able to hear you clearly. Yeah. Okay. I heard about the collapse consolidation. I heard
as
about
well, it's noted within.
Okay. What else you are seeing? I'm sorry, I didn't hear part of it. Yeah. Can you just
reading the? Yes, ma'am.
Okay.
Shall I start from the beginning, ma'am?
No, just one question based on this. What do you think they should do immediately when they see like this? Should they operate or should they do any endovascular?
Saccular aneurysm.
Again, answer actually will depend on the sender wise, because both can argue it. But often, if the sender has a lot of good cardiologists with endovascular procedures expert, they will actually first go for endovascular repair. Only if that is not possible, they will go for the surgical involvement. Sometimes, if it's a smaller one, we can actually treat medically also, depending again on how the patient is clinically. But otherwise, the first treatment will be endovascular treatment. That's the most common, especially if the endovascular procedure expert is those who can do are available. That will be the first way to do it. So what are you seeing? What procedure is being done?
TMR procedure, ma'am.
Okay.
So I can see the radiograph structure. Possibly that is a stunt. And there is left pleural effusion with the collapse consolidation of the underlying lung segments. Then the surrounding inflammatory changes, that is the thickening of the esophageal wall, is increased compared to the previous study. And adjacent to the aorta, I can see there is a hypertense collection with a few air pockets within. So with this, there is a two possibilities.
This also we can look at this.
Okay.
Yeah. Anything you want to add? Okay, now that anyway, I think I'll show you these images also.
Yes, ma'am. This one, these are the post-contrast administration. And the visualized images, there is a presence of penetrating atherosclerotic ulcer in the arch of aorta with a mild eccentric thrombus. Otherwise, there is no contrast.
So what do you see here? Dr. Vaishak, can you see?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yeah, what do you see here? Yeah, I think this probably is a good. What do you see here?
Yes, ma'am.
You saw how it was before the procedure. Now what do you see?
Now there is a presence of an possibly a collection with air pockets around the aorta. With few ill-defined hyperdense areas are there, and there is no active contrast extravasation.
Let's follow it down. Let's follow it down. You mentioned about what is the structure here?
Esophagus, ma'am.
Okay, let's go down and see what is happening with the esophagus. So this was the section just above it, okay?
Yes,
and
then there's a dilatation of esophagus. Here. Yes, ma'am.
Okay, and
dilatation of the esophagus. And
how is the wall? Sorry, I didn't hear you.
There's a collection with air pockets. Possibly any infective collection.
Okay, I am not fully, see when we say the word, you saw the lumen, how it was coming, right? Okay, now let's see this also. I think you may get how the, now look at the esophagus, it's coming here.
Yes, ma'am.
And this is like this.
There is growth, a soft tissue growth within esophagus.
So soft tissue growth is probably, I would say, don't use such words because see, you know that this has happened within a week, right? Yes. Isn't it? So it can't be a growth. Growth is something like, you know, it is a mass which is growing. So that is not possible. So do you want to think of anything else? So first thing is, are you convinced that this is a collection or is it something in the esophagus? Which one do you think?
Since there is a proximal esophageal dilatation, I think it is within the esophagus, predominantly.
Yeah. I know this is not a very easy case. I'm just giving you clues to how to go ahead with it. Because if it was a collection, no, I would have expected a lot of fat stranding in the surrounding. But you can still see that oval shaped kind of, it's like something is being stretched and it's still trying to cover. But what is so striking? Is there anything? See, you saw how it was here, right? The prior to that. You could see this is the esophagus, or at least you can make out this is esophagus, and this you think is the aorta, right? Yes. Now let's see, are you able to make that out?
No.
Do you know where the aorta ends and where the esophagus starts?
No,
we can't. No, it's all like in one system, no, isn't it?
Yes, ma'am.
And
yes,
you're seeing the esophagus, it's all the esophagus. So what is happening? So what can happen is, so when the wall is very dehiscent or when the wall is very weak, sometimes even though that's a procedure to be done for as a part of treatment, but even that can cause a dehiscence or a rupture to that wall. So now there is a frank aortoesophageal communication. That's what you're seeing. So this was the part which had the lumen. So that this part was where we saw the saccular aneurysm. Now that part is freely. Previously, we saw a peripheral thrombus. Now that again was an infective focus. Now that is communicating directly with this esophagus. So there is what you can say based on this image. You can say that I can see there is an endovascular stent. There is contrast inside that, and following surrounding that is the thickened esophageal wall, which is seen in continuity with the aortic wall. That much only we can say, or in continuity with the site where I saw the aneurysm previously. Because I can't make out where the aortic wall, the aneurysm ends, or where the esophagus. It's all communicating together. And that is why even here you saw how it was looking on the post-contrast, right? Now we can go back to the post-contrast and see. So this was the site of the previous saccular aneurysm. Now you can see that it has got a little irregular shape and it is communicating with this esophagus. Can you make that out? So it was an aortic esophageal communication has happened. Even though the stent was put for treatment, but because the wall was very dehiscent and because the infection was also didn't get controlled, it actually worsened the whole situation. So then what happened? Then they were able to find the organism. It was actually an enterococcus, and then they treated the enterococcus, and within we actually had a follow-up CT for this case, and within I think the 6-week CT, it had significantly reduced, but that communication was still not completely closed by then. So the plan was for that the dehiscent wall to form by itself, and then they will, if required, they can put a patch over it. But all the inflammation settled down once they treated the organism. I know this is a very not very uncommon case, but things which you should remember is, so whenever you see a saccular aneurysm, look for any infective focus adjacent to it. Okay. Second thing, you mentioned about the contrast density inside this. So you can always raise the possibility that any communication we cannot rule out. If we are not able to say for sure that there is a oral contrast given. Now looking back, we are still not sure whether there was a communication even at this point. We are not sure, but definitely once we did the procedure, we can make out that there is a direct communication. It's became like on this aorta and esophagus is now one system. Okay. Now but I appreciate you picked up all the findings of other things, like, you had all the resultant findings like pleural effusion, collapse consolidation, there is infection in the surrounding, all those you have picked up. I know this is a very uncommon presentation. We don't expect this kind of presentation to happen, but always mycotic aneurysm, look for the surrounding structures, where is the infective focus, and also look for any direct communication. Often that happens because if the wall is dehiscent, they can have direct communication into a node or into esophagus or into bronchus. So these things you should look for. Okay. Okay. Anyone else would like to ask any question?
This is such a good case, Dr. Leena. Like as you said, it's not very common, but then we may come across it once in a while. We also had a case of mycotic aneurysm due to an adjacent vertebral body spondylosis. Sometime back, infective foci in the vertebral body at the lumbar level predisposing to an aneurysm in the aorta, and this was stented. So you get it once in a while.
Yeah, it's good to know, because once we see these kind of cases, next time we will definitely look for it. That's the good thing about these kind of cases, when it is very rare, but once we see it, I think we will always look for it. And because we have tuberculosis, I am not sure how common it is. At least in our part, the tuberculosis is common. Like we see aorta, lymph node, necrotic lymph nodes communicating with aorta, all those with the bronchus, all these are quite common. So once you see saccular aneurysm, always look for these kind of other associated things. Shall I go to the next case?
I think are there any questions in the chat box?
Aortoesophageal fistulous communication. Yes, yeah. So second, after the procedure, that's what has happened. It became like a frank communication. It became like on one common system, the aorta and the esophagus. So it was a quite a dreaded situation, but thankfully patient settled down with antibiotics. Within 6 weeks, patient all the inflammation settled down. But again, that communication, I think if it's not settling down, if that organized tissue is not formed, they have to put a patch. So that is how it, and patient has to be milk per oral, because they cannot have oral intake. Okay, why is contrast not seeing into the esophagus? Yeah, so we put a stent, right? So this is already an endovascular stent is done. So we actually disconnected the saccular aneurysm from the esophagus. So now the contrast is only within the stent, but the inflammation is all outside. That is what is extending into the esophagus. unless there is a leak, endovascular leak, we will not see the esophagus opacified. Okay, I think shall I go?
There are yeah, no more questions, and then I think we'll move on to the last case, case number 4, and Dr. Nisreen, this is for you.
Yes, ma'am.
Let me just open the case. Okay. Okay, Dr. Nasreen, again, this is a cardiac MR image. You don't have to worry about it, whether I'm not sure how much you have seen, because I think usually in most of the centers, even in our center, the PGs don't regularly report cardiac MR. So I'm not expecting you to know all the details of it, but take it as how you are reporting a CT thorax, or that way you can start, and then you can look at the late gadolinium images. Is there anything which is striking which you can find out? Okay, so is that okay, Dr. Nasreen?
Yes, ma'am. Yes, ma'am.
Okay, so this is the first set of image, and this is the next. This is next. Some of these actually I put it as still images because I didn't want it to get, I mean, ideally some of these can be cine images, but it's just to know you how it grossly looking. We are not looking into any, the wall motion abnormalities at this point, because it's, I mean, those are good to look at it, but in this particular case, we have more findings than that. So I thought we will concentrate on those findings, and it's also to just to know the various causes of cardiomyopathy, and also to how to look into the cardiomyopathy case. That is my intention of this. Okay, let's start with the first set of image. Now I'll just give you, so just assume this is your CT thorax. It's just MR sections. So in depending on the scanner, they will call these, basically it's a mixture of T1, T2, what we call a trophy sequence. Okay, so is there any abnormality you are able to find in this particular set of images?
Ma'am, I'm seeing some onset signal intensities in the upper lobe parenchyma in the prairie bronchovascular regions. Okay,
very good. I think that is the thing which you should pick up, because I think that is more than enough for you to pick up in this particular. So when you see that, is there anything else you want to look for? Like it may be there, may not be there, but what else will you look for?
Mediastinal lymphadenopathy. I'm not seeing any paratracheal lymphadenopathy to the extent visualized.
Okay, I know maybe some images are not great. There may be some small notes, not very big ones. Now, what was in your mind when you saw this images?
Ma'am, any probably fibrosis, fibrotic changes.
Okay, anything else? When you say fibrosis, what kind of fibrosis are you talking about? Fibrosis related to what?
Related to sarcoidosis, maybe.
So whenever you see, oh, this was your CT image, you can make out that there is some stuff you can see, something which is appearing like nodules and also. What do you think that could be?
Or else, ma'am, it may be a ground glass opacity.
Usually ground glass we may not pick up on the MRI, because that will be faint, and we most often, or unless it is little more denser, those things only we may pick up on the lung. So no, what I was trying to say was, when we use the word fibrosis, you are like saying that it's kind of end stage. What I'm trying to say is, you can say that it's on some peribronchovascular lesions. It could be an active or inactive. I mean, like a fibrosis also, it's possible. But to be honest, I'm not seeing a definite tractional bronchiectasis or anything like how you see on the CT to say for sure. right? So what you can see is, at least I can see some nodularity along the central interstitium or peribronchosvascular region. That much you can say. Okay.
Yes,
so sometimes don't, what we are not able to say, don't say. I understand you are looking for sarcoidosis. Anything else when you say central peribronchovascular? What is other differential you have on CT? Suppose this is CT. You have not seen the cardiac. You are only seeing some central peribronchovascular or perilymphatic lesion. What else is there in your mind along with sarcoid? Silicosis, right? On the CT, these are the two things which comes. But again, sarcoid will have more central peribronchovascular involvement. And you said, I'm not seeing any obvious lymph nodes also. That's fine. Probably there is some subcentimetric nodes. Again, that is not necessarily have to be definite sarcoid. It could be as part of some reactive also, because this much lymph nodes can be seen in other causes also. Let's move to the next one. So based on this, is there anything extra finding which you are thinking of?
The altered signal intensities are also seen in the lung apices as well, in the peribronchovascular region.
Okay. Any added? So in this, so remember, these are the trophy sequences. These are like our axial CT images. So things which you can comment, you mentioned about lymph nodes. Second, any gross abnormality in the lung, like consolidation, nodules, or pleural effusion. These are the things which you can comment. Other thing is looking at the cardiac chamber. Is there any gross enlargement of any of the chamber? Is it there?
Cardiac is dilated and enlarged.
Which chamber appears dilated?
Especially the left ventricle.
Okay,
and the right ventricle, and also the right ventricle.
Okay, I'm not saying a complete no, but I wouldn't really think that it's really, because these are coned down views, no? So it may look little magnified also. Okay, maybe you can say the ventricles appear prominent. It's not like definitely significantly enlarged, maybe slightly prominent, I would say. Okay, let's move to this image. Now, actually, this is the 4-chamber Cine images. Now, in the cardiac MR, there will be one is our localizers, and then we decide when we take the Cine images. So usually the common Cine images are short axis, for 2-chamber, 4-chamber, 3-chamber. Okay, now each of these chambers will look at each particular segment of the ventricular myocardium. Okay, I don't want to, but this is a left ventricle. So any idea which segment this will be?
Segment of I did not get it.
Okay, so what happens is 4-chamber, we will be seeing the infroseptum and androlateral. Okay, and this is the anterior free wall of the RV, but it's a LV which we are more concerned with respect to the segment. So this will be the infroseptum and the androlateral, and this is a 2-chamber view. This will be the anterior and the inferior. And this is a 3-chamber view. This will be the androseptum and infrolateral. Okay. And then this is what we call the stir image. So now, yeah. So these 3 images, the 4-chamber, 2-chamber, and the 3-chamber. So when we see the Cine images, you can look for the regional wall motion abnormality. I understand you all had a class on viability, so I'm not going more into those. Now, in this particular case, there was no wall motion abnormality, so that's why I didn't bring in the Cine images. But that is what you're looking for on the Cine images. So each of these Cine images, like the 4-chamber will tell us about infroseptum androlateral, and the 2-chamber will tell us about the anterior and inferior. 3-chamber will tell us about the androseptum and infrolateral, and short axis Cine will tell us about all the segments except the apex. Apex is better appreciated on the 2-chamber and 4-chamber images. Okay, so that is the Cine images for. And then we have the stir image. Now, why do we do the stir image?
To look for edema or acute inflammation.
Okay, yeah, edema, myocardial edema, acute myocarditis. So what will you see?
Hyperintensity Severe hyperintensity involving the
Do you think
myocardium.
all the images are normal, or is any of them looking abnormal?
Ma'am, subendocardium is appearing hyperintense, but that is normal in a stereo image.
Yeah, so what you're mentioning is this set of at the blood pool interface, myocardium and blood pool interface, there can be a hyperintensity normally, so that is normal. But other than that, do you think anything is abnormal? Like if you look here, look here, look here, look here, and all these 6 images, any of them looking little more hyperintense? Okay, I know it may be sometimes difficult when you are seeing it on the PowerPoint. So this image, actually, if you compare with this previous images, no, like how this is what we normally expect to see. There is a mild hyperintensity. Okay, so whenever we see a mild hyperintensity, you should always compare the value of the intensity value of this with the adjacent muscle. So some people say more than 2.5, some people take 2, some people take subjective. That again, it's not like a hardcore rule. If you can make this quantitative, that will be more values in the sense, especially in research, and it will be of definitely. But sometimes we do look at the subjectively also. Okay, so for me now, I can tell you subjectively, it looks like there is a mild hyperintensity in these 2 segments compared to all the rest of the sections. These 2, there is a mild hyperintensity in the septal region. Now this is a short axis view. So again here, this is the anterior, this is the lateral, this is the septum, and this is the inferior. And we take sections and we tell them with respect to basal, mid cavity, and apical, and then apex. So basal has 6 segments, that is anterior, inferior. Now lateral and septal, we divide them as androseptal, androlateral, and infroseptal, and lateral we divide again as androlateral, infrolateral. So that's how you get a 6 segments at the base. This is the mid cavity, same 6 segments at the basal. And then when it goes to the next level, that's the apical level, you have 4. That is the apical, inferior, septal, and lateral. Okay. So let's move. Yeah, I think I had those sections. So this is at the apical level. Okay, now this is that again the blood pool interface which you normally see. That is what you are seeing on the RV side also. Now this is also the regular artifact, but when it comes here, you can again see there is that entire septum is showing mildly hyperintense. Okay, so this is the late gadolinium enhancement. So here, what are you looking for?
Late gadolinium enhancement, ma'am.
Yeah, how will it look? How would it look?
There is nulling of normal myocardium. So late gadolinium induced enhancement will be seen as bright signal.
Yeah.
Here it is seen in the mid myocardium of the septum.
Okay.
Crescent.
So yeah, so this is, if you look at it, once you start seeing the papillary muscles, this is at the level of the mid cavity. So this is at the mid cavity septum. That is both androseptum and infroseptum is showing the late gadolinium enhancement. So what did you say? Mid? Did you say
mid myocardial?
So what other type of late gadolinium enhancement have you heard of? What are the different types of late gadolinium enhancement? So this you said is mid myocardial. What other types are there?
Ma'am, subendocardial and subepicardial.
Okay, subendocardial, where will you see?
Mostly in the case of ischemia, ma'am.
Okay. Can any non-ischemic pathology show a subendocardial?
Yes, ma'am. Amyloidosis.
Okay, very good.
Systemic sclerosis.
Okay. So when you see mid myocardial enhancement, what are the things which comes to your mind? What are your differentials?
Ma'am, dilated cardiomyopathy.
Okay, I probably would keep that as a, that is like if you are ruling out other things, you can say that as, it could also be. So when you say dilated cardiomyopathy as a cause for what? As what is causing dilated cardiomyopathy?
It can be either idiopathic or secondary.
Okay, let's not go into dilated cardiomyopathy. Tell me we will come to that. Mid myocardial enhancement, late gadolinium enhancement, what are the differentials? Okay, you mentioned dilated cardiomyopathy. I will come to that. What are the causes?
Myocarditis.
Okay, very good.
Then hypertrophic cardiomyopathy.
Okay. Is there any particular terminology they use for in hypertrophic cardiomyopathy? I agree it is mid myocardial, but what else will it be?
It will be at the insertion points of the right ventricular, anterior and posterior insertion points.
Okay. In addition, even in the hypertrophy segments, it will not be like this very diffuse. It will be usually patchy, cloudy mid myocardial enhancement. That's the word. That's how it looks like. Whereas here, it is like a very diffuse. So you mentioned acute myocarditis. Anything else in our country?
Sarcoidosis.
Yeah, I would use the word granulomatous cardiomyopathy, but having said that, you saw something in the trophy sequence, right? So with that, you probably can raise the possibility of sarcoidosis in this case. But otherwise, suppose if you didn't have any finding on the trophy sequence, you are only seeing this, the differential should be myocarditis in the appropriate clinical setting, or granulomatous cardiomyopathy like TB or sarcoid. Both TB and sarcoid can have a similar picture. Not necessarily always have to be, though the typical description is nodular mid-myocardial late gadolinium enhancement for granulomatous. It needn't be. It can be very diffuse also. And for sarcoidosis, which is, do you know, which is a common site of involvement?
Subepicardial, ma'am.
I mean, the site means which segment is commonly involved?
Interventricular septum.
Yeah, it's usually the basal androseptum, which is more commonly involved. Okay, now I'll come back to your dilated cardiomyopathy. The word, see, there is a terminology called mid-myocardial striae, which is related to mid-myocardial fibrosis related to idiopathic dilated cardiomyopathy. But that probably is not the, so whenever we see mid-myocardial late gadolinium enhancement, that is not the first thing we will say. First, we should look for the cause for it, like whether it is myocarditis, like a viral myocarditis, or is it a granulomatous, or is there any other infiltrative pathology we can look for. So in the absence of this, it could also be related to dilated cardiomyopathy, and it's a common finding. Actually, what you mentioned is right. A lot of our dilated cardiomyopathy patients, you will see this mid-myocardial striae, but it will not usually be this hyper intense. It will be little more milder intense, and it will be just at the basal androseptum alone. It won't be like quite diffusely seen in this patient. Like if you see in this patient, actually you can see over here, it's also coming partly here in patients other, I'm not sure whether, yeah. So this the entire septum is having that. And yeah, I think that those are the main, I think that was my last image. Okay. So this much hyperintensity and this diffuse involvement is not that common with myocardial striae. Often will be in this basal androseptum, but it is possible. But maybe we should say the other causes, or first rule out those causes, because those are treatable causes. Like if you find that it is TB or sarcoid, then you can treat accordingly and patient will improve. Whereas when it is just related to dilated cardiomyopathy, there is we can only prevent the bad outcomes, like whether sudden they can, if the function is low, they have to put ICD, things like that. But if it is something which is treatable, that those things we should look for. Okay.
Yes, ma'am.
So in this case, the main findings, can you summarize?
Ma'am, there are altered signal intensities in the peribronchiovascular regions of the upper lobe parenchyma.
Okay.
Also, there is a diffuse stereohyperintensity involving the septal myocardium.
Okay.
With late gadolinium induced enhancement seen diffusely involving the mid myocardium of the septum.
Okay, very good. So bringing all these features together, the differentials will be granulomatous. But again, because of the peribronchovascular involvement, I would consider sarcoidosis. That's how you can say. Because TB usually won't have a central peribronchovascular. It will be like more of nodules here and there, or a consolidation with cavitation. Or sometimes the necrotic nodes you will see. None of those are seen. So then sarcoid is considered more likely. Okay, I think this session was a little long, but I know it is a longer case. Anyone else would like to ask questions?
Anything in the chat box? I don't think there are any questions in the chat box.
Okay.
Yeah, I think we have very well covered the practical aspects of this non-ischemic causes of very well. And then I think we'll move on to the sports section. And I think Dr. Nisreen can stay. And we have 7+7 spotters. And the sports session is especially meant for Dr. Gomati because she feels that no discussion is complete without some sports. So and that's why we have kept. I think Nisreen is there on the line.
Yeah.
Yes, ma'am.
Okay, so first will be, okay, let me just, I think it is still showing the same case. Let me close that. Okay, 1 second. And this is the first one. Yeah. Okay. Okay, let's just run through it because I know it's quite long time, I think. Okay. Okay, what are the findings, Nasreen?
Wall thickening, noted involving the in the aortic branches.
Anything striking? Dr. Nasreen, are you?
Ma'am, arthritis, Takayasu arthritis.
Sorry, I didn't hear you.
Takayasu arthritis.
Okay, very good. So one other question is if you can, especially for your Viva, you should be able to write or tell what type. Do you know which type? I know this is limited section. From these sections, what can say? I have not provided you the rest of aorta. So from these section, assume this is only, this much is only involved. So what will you say?
Branch. No.
Okay, so that is something we should you should read about. That is type 1. So if it's only arch branches, but then I have not provided you all the images. So actually, it's an incomplete study to comment on the type. But you can say like this: if it's only the aortic arch branch involvement, then it is type 1. Like that, you can mention. Okay, let's move to the next case. Okay, anything abnormal, normal? See, spotters often, I mean, it will be always abnormal. So
left, the pulmonary vein draining to the left atrium is dilated.
no,
There is also left atrium is another vein is coronary artery arising from the
very good.
Arising from the pulmonary artery.
Which coronary artery is arising from the pulmonary artery?
Left. Left.
So what do you call that?
Anomalous left coronary artery arising from the Al-Kappa.
Al-Kappa, very good.
Scimitar syndrome.
Are you able to see a Turkish sword? I'm not able to see. See, the clue for this case, this kind of cases is when everything looks kind of normal, look at what?
Aortic.
Okay, what in the aorta?
And
I know this is, I think I have limitations of making it zoom. Otherwise, like
the reverse 3 sign. No.
Yeah.
3 sign. Coarctation of aorta.
Yes, very good. So what else will you look for?
Rib notching, inferior rib notching.
Yeah, I'm not sure whether you're able to see. Actually, there are rib notchings here. I'm not sure whether you're able to see, but this is fair enough because this is what I wanted to pick up because this is coarctation of aorta. Very good. Next. I understand you all had a class on this. That's why I put this up, but I will just stop this over here and stop this here. Okay. Now, compare, you saw the previous MR now, no? So this is a different set of MR images. I just wanted to know, I mean, see, is it looking, this, anything is abnormal here? Can you, I understand you all had a class on this, so that's why I put this up.
There is late gadolinium enhancement and the subendocardial region of the left ventricle, and the ventricular.
So it
There is
is thinned out, right?
thinned out.
So what does that mean?
The fibrofatty. No.
No. So whenever there is thinning, that is means it's completely infarcted. Okay, so this is actually here, the septum, this anteroseptum, the apical septum, all those will be for LAD territory. So this is a transmural infarct in the LAD territory. I know it's difficult because so many images you have to look for, but I just kept few images. So when you see something like this, see, look at the wall, the rest of the wall compared to this, you know that it's markedly thinned out. So that's like completely infarcted tissue. See the transmural infarct, that is what you are seeing here. So the entire myocardial wall is it is infarcted, and it is also involving in the basal septum, more anteroseptum, part of the infroseptum, lateral wall. But if you say that this is an LAD territory infarct, that will be good. But I mean, I don't think they will keep Cine images for your spotters. I just kept it because I just understood that just to brush up your knowledge. Don't stressed about seeing these kind of images. Okay, let's move to the next case. Okay, it's not moving. I'll just move here. Okay, this is again an MR image. I'll just let you. This is the non-contrast. Tell me. This is a contrast image. So I think if you look here, you will get the answer here, because otherwise sometimes the contrast image can be confusing. Is anything looking abnormal here?
The right ventricular wall shows fibrosis with late gadolinium induced enhancement. Right ventricular free wall.
You are seeing later. Actually, this is the wall. This is just outside the wall. So what will that be? And also you look here. Is there anything you are seeing?
Pericarditis. Pericardial thickening.
This is actually a gross thickening. Very good. And this is
constrictive pericarditis. Constrictive. Hello. Constrictive pericarditis. Ma'am, I'm not able to hear. Hello.
Okay. Yeah. I connect. There is a problem. Hello.
Yes, ma'am. Yes.
Hear me?
Ma'am.
Dr. Leena?
Okay, I'll just. Yeah, I can hear me. Yeah, I can hear you.
Yeah. Your voice was breaking in between, but now I think it's fine.
Are you able to hear now?
Yes, ma'am, it is audible.
Okay. I think there was some connection problem. I'll just start sharing it again. Okay, so this was, what I was trying to tell was it was a still image. On the still image, to comment on constrictive pericarditis in an MR image is difficult. So at least if you say this much is more than enough, that there is a concentric pericardial thickening which is showing enhancement, and likely a tubercular pericarditis. There could be other causes also, but it could be tubercular. I think that is more than enough, because the typical finding for constrictive pericarditis, like a septal bounce, all those things needs a Cine image. I have not provided you that, so I didn't expect you, but that is a good thought, like, looking for constrictive pericarditis. Okay, let's move to this one.
My pulmonary edema.
Very good. It's something what we commonly see. Actually, there are curly B lines here. And the clue here is already there is left atrial enlargement, and you can see all the fluffy opacity. So this is a garden variety, what we see in our ICUs, or even when patient coming with acute dyspnea due to pulmonary edema. So we should be very careful. So first is to look for this curly B lines, and then you can connect everything else, looking for fluffy opacities, the central distribution, and also looking for left atrial enlargement. Which other chamber is enlarged here for sure?
Left ventricle.
Why? Yeah, so whenever there is elongation of the left cardiac border, and when there is downsloping of the apex, that is left ventricular dilatation. Okay. Oh, okay. Now what is this? I'm not sure. Actually, I put all the spotters together thinking that I'm not sure how many I have shown. You have a number? Yeah, I think this is your last one. This is your last one, I think, no? Yeah, because this is your last case. Okay. Yeah.
This is egg on a string appearance.
Usually egg on a string, how will be that superior mediastinum? How it will be more narrowed, right? This is not that narrow. First look at the lung fields, lung zones. I shouldn't be using the word lung field, lung zones. And then you look at the cardiac. Is there any clue? Is there any named shape? Those are the things.
Snowman, figure of 8.
Are you able to see a figure of 8? Okay, let's look at it one by one. What do you think about the lung zones?
There are prominent vasculature, bronchovascular, prominent.
I thought it is not there. Just look, are you able to see the vessels that prominent? Is this how a prominent vessels will look like? No, right? I know this is something what we can miss easily, but definitely there is two prominent vessels. That definitely not there. You see, usually in a child, you will see more, the vessels will be a little more prominent than the adults, right? And this one, definitely it is not prominent. If at all, it is oligemia, isn't it? See, look at the vessels on, there are no vessels actually seen, hardly few vessels you can see here and there, isn't it? Then once you see oligemia, what comes to your mind?
VSD,
what will you expect? Oligemia or plethora? It should be plethora, right? Because there is more vessel going into the, so it should be plethora. It's not oligemia. Where will you see oligemia in a child? Like, I mean, once they grow up, things can change, but okay, now let's look here. What do you think? Normally, how should it be? Normally, it will go like this, right?
Yes, ma'am. Yes.
Here it is.
The
concave. Isn't it? Where will you see that? So that is?
Sorry, ma'am.
Okay, so whenever the pulmonary bay or the pulmonary vessel is not developed, that is pulmonary atresia, or if there is narrowing in the infundibulum when the pulmonary arteries are narrowed, these are the conditions where you get the pulmonary bay being concave. Okay, so then you look for the other associated findings, because in your spotters, usually it will be something more common thing. So, and your, where is the apex? Apex is here, isn't it? Normally your apex should be here. So it is slightly above. So putting these things together, so there is oligemia, there is concavity at the pulmonary bay, and there is upturned apex. So this is boot-shaped heart. You know, the typical boot is very difficult to, very difficult to find a very typical, extremely nice boot shape. But this you can see the upturn and this concavity, and there is oligemia. I think that is enough to call it as a boot-shaped heart seen with
Thales tetralogy.
Okay, very good. Okay, now Dr. Vaishak, shall we continue? I think mine, it's Dr. Vaishak can take.
Yes, ma'am.
Okay. Okay, I will just stop here so that, yeah. Okay, I think this much is enough. So this is how it is, the ventricle. Okay, what do you think? So first, let's look at these are the non-contrasting images. What do you think?
Apical HOCM, ma'am.
Yeah, hypertrophic cardiomyopathy. It's almost concentric. I agree. It is more in the apical, but it's almost. And this is the typical the enhancement pattern we were talking about. There it will be more mid-myocardial, but it will be more patchy and cloudy in some areas. Like here, it is kind of cloudy. Okay, this was also late gadolinium enhancement. I have tried to cover it. Just okay, that's fine. Okay, let's move to the next case. Okay, I think it is not moving to the next one. Okay.
Map cast, ma'am.
Map cast will be seen between.
Aorta pulmonary.
Yeah. So are you seeing anything coming out of aorta?
No, no.
So this is at the level of aortic root, right? So what is this?
Yes, ma'am. Any
What is
acute
this?
angulation on interatrial.
No, what comes out
LAD,
of
ma'am. LAD, ma'am. LMC and LAD.
Yeah, so this is the left main giving to LAD. Okay, now so and you are seeing some extra things here, but MAPCA should be here, right? It should be coming from the aorta. That is not there, isn't it? We are seeing something else.
In the next image, there is in the main pulmonary artery one more vessel is seen arising.
Okay, okay. So that is what I was. So this is actually the section just below it. Yeah, this is arcapa. So this is the right coronary artery coming from the main pulmonary artery. And we saw the alcapa already. So this is the arcapa. And there are collaterals formed between the LAD and the RC. Okay. Next.
Stanford type A dissection.
Why did you say Stanford type A?
It's involving ascending aorta as well.
Okay,
as well as
very
root.
good. And ascending aorta, where is the proximal end in this case?
I mean, the fourth image, I think any root is involved. Ma'am.
Yeah, very good. So it is almost going up to the right coronary artery origin. Okay.
Yes, ma'am.
So I'm giving you two chest radiograph of the same patient. This is 2 years back and this is the present one. What is your diagnosis? Anything is striking here compared to this one?
My cardiomegaly is there, but I'm not sure is it because of exposure factors.
Oh, no, I agree there is cardiomegaly because
Yes.
it is not just the exposure factors. What made you think is there an exposure factor? What are you seeing there?
The opacities in the lower lung zones are quite increased.
Okay. Do you want to look at it the other way?
Compared to the
So
previous
you are
image, it has
saying-
improved. Upper and mid zones in opacities.
Upper and mid zone opacities. Okay. Now, what do you think about these two areas? Do you think that it's normal or abnormal? See, this was a normal X-ray at 2 years back. Okay.
Okay.
Compared to that, is this normal or abnormal? And which
you added
chambers
media.
are-
If you added mediastinal opacities are seen. Chamber dilation. Some
How are the
coronal
pulmonary
coronal splaying is also there, and some pulmonary arteries are also appears dilated or prominent.
Okay, pulmonary arteries are dilated, cardiac appears dilated. Which all chambers of cardiac appears dilated? You said the carina,
Coronal
okay,
spleen.
maybe, but more than that, anything else is dilated?
LV, ma'am.
No, it's actually the right cardiac border is also projected. See how much is here beyond the right cardiac border, and even the right ventricle, no, it's became more rounded. That is seen with right ventricular enlargement. So this is right atrium and right ventricular enlargement is seen. Pulmonary artery is dilated. So what are we looking at?
PH, ma'am.
Yeah. So what is the cause for PH? Okay, I shall move to the next case because I think we are little. Whenever you see this, no, I showed you a normal X-ray. So this is what we normally expect to see, right? So here, what is seeing is oligemia. This oligemia is something which we can easily miss, but in this case, imagine. So when we are saying that, if I would have given you the history, I'm sure you would have said the answer, but I didn't give the history. This was a patient who had an ankle fracture. She was immobilized for 2 weeks. Okay, now what do you see? Pardon?
Chronic pulmonary thromboembolism.
Yeah, so this patient, what are you looking at? On the chest radiograph, what are you seeing?
Oligemia.
This is the oligemia. Okay,
yes,
so
oligemia,
again, something which we should tune to our heart. We should keep seeing images of oligemia, something which we can easily miss out. But the clue here is that this is the normal X-ray for her 2 years back, and this is how it is looking now with right chamber enlargement, pulmonary artery enlargement. So then you are finding this. So then you can think, okay, this is likely to be oligemia. What is that sign called? Okay, you should look at all the signs of acute pulmonary embolism, chronic embolism. Okay, these are very important.
Yes, Hampton sign, Fala sign, Westermarck sign.
Yeah, so this is the Westermarck sign. Okay, and we should know all the things about chronic pulmonary embolism and acute pulmonary embolism. Okay, next diagnosis.
This pericardial calcification, two possibility in a TB pericarditis, but there are some sternal clips also post-surgical. There is an hematoma or any pericardial infective cause also secondary to that also they can be a calcified pericarditis.
So in this case, yeah, I think you can say calcific, probably consecutive pericarditis. That will be enough. Now the cause, I agree with you. It could be whether surgical because patient already had CABG. Okay, this one. Which chamber is enlarged?
RA, ma'am.
RA is mildly enlarged, I would say, but not much. You have some clues in the lung parenchyma. What are these?
Yes, pulmonary venous hypertension. This
Okay,
Hankler sign, reverse mustache, and there is a prominent cephalization of the pulmonary vessels.
Okay, so now what are you seeing here? What are all these
dilated LA, dilated LA, as well as LA. Double atrial shadow. Double atrial shadow.
So what are you seeing? This is what?
Dilated left atrial appendage.
Okay, so where will you see that?
Valvular stenosis, ma'am.
Which etiology?
MS, RHT.
Etiology. Yeah, rheumatic. So it's all common with rheumatic mitral stenosis. Okay, this one.
Cardiac TAPVC, figure of it.
Okay. Yeah, I think that ends up with our spotters. Okay, well done.
Yeah, so that was an excellent section that you have been having for the last 2 hours, and we thank you, Dr. Leena, for that. And it's one of the best sessions we ever had. And thank you for the excellent selection of cases, and the discussion was very crisp and clear, and each case was unique with so many teaching points. And I'm sure like whoever has attended the session and who would get similar cases would get full marks. So the entire credit goes on to you, Dr. Leena. And
thank you, ma'am.
So to the
I'd like
PG
to thank Madam as well as IRI for giving this wonderful opportunity to participate in this academic session. Thank you.
Thank you. And Dr. Venu? Dr. Venu? Dr. Venu is here. Would you like to say something?
Yeah, madam. Okay. I think no. It was a very exhaustive session, and 4 cases now. 4 cases plus 16 spotters now. And I think Dr. Nisri and Dr. Vaishak had very hefty time. And when they answered no, actually I was a little nervous now whether they were going to answer that or not. And in many sessions, I mean many areas actually I am also totally unaware of, because nowadays actually I am not in touch with these areas now. So I also learned a lot, and thank you very much, Dr. Lina. And you actually put it everything systematically, so that even one doesn't know anything now, that at least they can gain something by hearing you. Thank you very
true,
much.
Dr. Venu. Very true. What Dr. Venu said is absolutely true. And I would also like to thank Dr. Gina and Dr. Josie, who willingly permitted their students to be here for this session. And then I have to thank the ever enthusiastic team of organizers behind this, Dr. Gomadi, Dr. Rijo, Dr. Venugopal, Dr. Shenoy, and other zonal coordinators without whom this wouldn't have materialized. And I also thank the MedPiper team for the support in conducting the event. And I take this opportunity to thank each and every one of you who have made this a grand success. I think we are closing the session for today. Shall we close the session, Dr. Venu? I don't think Dr. Gomadi is here.
I just want to thank, extend my thanks also, because it's a good opportunity to interact, and I'm so happy with the residents also, because it's not easy. I know, I remember how I was as a resident to speak in a forum like this when so many people are listening. It's not easy, but I'm really appreciative, and I think I also appreciate the teachers, the faculties who took that effort to bring them up in front. So that's also quite encouraging, and it's a very nice interactive session, and thanks to the organizers.
Thank you, Dr. Lina, once again. So we are closing the session for today, and I request all to attend the session on imaging of vasculitis on Saturday, the February 26th. And so this is going to be our last topic of cardiovascular system. Thank you all once again. Good night.
Thank you.
Thank you.
Good night.
Thank you.
Thank you, ma'am. Thank you, ma'am. Good night.